Good afternoon, everyone. I am Garrett Schmidt, the Managing Editor for ACO Exhibit Hall, and I would like to welcome you to today's webinar, Risk Adjustment Coding and its Impact on ACO Performance. I know we've still got some people rolling in here, so that is okay, but a few items of note here before we get started. First of all attendees have joined to the webinar today in listen-only mode, so you don't have to worry about muting your mic or anything. We can't hear you. Also, I would like to inform everyone that this webinar is being recorded, so you will have the opportunity to rewatch the session and or share it with your colleagues later. And I'll tell you at the end about how and where you can do that. And finally, during the presentation, you will be able to submit questions, and we would encourage you to do so, to our presenters using the question mark icon at the top center of your screen. And we will answer as many of those as possible in the Q&A session at the end. Now, these questions are also being recorded, so even if we are unable to get to yours during the allotted time today, we will follow up to answer it via email after the webinar. Okay. In today's webinar, our presenters will discuss risk adjustment coding and its importance to ACO performance. The presentation will combine information from well-known industry research in addition to real-world examples and solutions. So let's meet our presenters here. Today we have Dr. Dan Fabius, who is the VP of Clinical Informatics and works with Continuum's clinical transformation efforts through data analysis and workflow optimization. And also we have Mr. Brian Wellens, who is the VP of Integrated Care and Value-Based Intelligence, and he oversees the population health operations and administrations of government and commercially sponsored value-based programs. And their bios are here on this slide if you want to take a quick look. As you can tell, these gentlemen are impressive individuals, and they are both with Continuum Health, which is a healthcare management company that supports ACO success through data analytics and insights, practice transformation, care coordination, cost of care strategies, and other value-based care services. So as our speakers take the stage today, we wanted to conduct a little poll so we can get to know our audience a little bit better, and you will also be able to see the answers. So I'm going to put a question on the screen here. And the first question, and you can answer this and just submit your vote, and it is, what type of provider organization are you working with? We have health, hospital system, health system and hospital, large independent multi-specialty medical groups, or if you're a smaller 5 or few physician practice or other. We'll take a second here to submit your votes. Okay, great. We'll go ahead and close the poll here. All right. And the second question is, in which type of risk reward model are you participating? MIPS, upside risk only, upside downside, other? You can take a second to answer. We'll give it about 10 more seconds. Okay, we got some interesting results here, and you should be able to see those as well on your screen. All right, we're going to close out the poll. All right, well, thank you all for participating in that. Now, without further delay, here is Mr. Wellens, who will begin our presentation. Welcome, Brian.
Hi, Garrett, and thank you very much for the introduction and overview, and welcome to everybody else on this webinar today. Really excited to talk to you about, provide some insights into risk coding and some real-world examples that, if you're not already applying today, might be a little more tangible to go into your populations and working with your patients. Before we get started on the risk coding aspect, Garrett did provide a little bit of insight into whom we are here at Continuum Health. And really what we're about here is we're a healthcare management firm, who's in the business of empowering providers and provider groups to be successful across the continuum of care. We work with independent providers, hospital-based ACOs, CINs, really, really different types of groups. And Dr. Dan Fabius and myself, have experience in working with the providers one-on-one, showing them data and some actionable items that they can take with it. As an organization, as well as optimize practice operations, really build around our relationships with the payers and providers, and close some of the gaps that might be there in communication. We activate and scale the new payment models, whether it's the Medicare Shared Savings Program, some of those other innovative programs, CPC Plus, then also the commercial value-based programs. And then we really just enable providers to spend more time with their patients. So what brings us together here today? It's really around risk adjustment. A lot of this might be a little bit of a review here for this first part. But the purpose of any of these risk models is really to provide some insight into the acuity of a population in order to predict future cost. CMS employs the HCC, or hierarchical condition category model. Specific to the MSSPs, it's the CMS model, but for the commercial models and Medicare Advantage, they're using the HHS. It's really around that predictive power of where the future spend is going to be. And using, the ICD-10 codes and diagnoses. So that's really what the purpose of this is about. And the way that it's utilized is to really set benchmarks or expected spend of your population. At which point, we're evaluating provider performance. Dr. Dan and myself, we'll talk to providers, and they'll come to us and say, well, our population is much riskier, or a higher level of acuity, and it's not really apples to apples. Well, that's in our conversation to say, we agree with you. These aren't necessarily the best methodologies, but we're here to support you and make sure you get credit for the patient population that you're serving. So it's within those benchmarks, whether it's through demographics or diagnoses, that we try and spend some time in understanding their population, some of the workflows to really optimize that. On this chart here, you can see in terms of establishing those risk scores. On the bottom axis, you can see what the predicted healthcare utilization is. That's really your risk score. And then on the left side, it's your predicted spend. The more specific your diagnosis gets, the further on the right-hand side of the quadrant that you're going to be. So higher risk score, higher expected cost. That's really, really what we get to today. Whether we're talking about our Medicare populations or our commercial populations, the similar concepts come together, whether it's the HCC model or some other models. In terms of the importance of it, it really does have a high impact on the benefit to actually being able to achieve shared savings. The additional dollars at which you might get paid, whether you're in an upside or a downside risk model, especially as a value-based care takes over in terms of the importance of the financial models. When we sit down and we'll have a couple real world examples here in a moment with providers, the first thing we always talk about, well, who's your population who's associated with you through the attribution model? It's important, at least on an annual basis, to get those patients in and really see the conditions that they have and the specificity around it. So on the bottom chart here, you can see if there's no conditions are coded, you might only get the demographics result on that. And there's something that we talk about, it's the RAF, the risk adjustment factor. The higher that is, then the higher the expected cost of care benchmark is going to be. Then there's patients who you might see, on a regular basis or semi-regular basis, where you get some of those conditions coded. You're going to get a higher risk adjustment factor, or RAF, which associate a higher benchmark. But then again, you're missing some of those opportunities. You might be working with some of your payers today that might be outside of the MSSPs or ACOs you work with that provide you with some of these lists that they call suspect conditions. That's something that is really tangible, can be actionable, and then you're able to take it to the practice and provider in real time. And we'll provide a little more insight into what we do on a regular basis and work with providers in accessing and using that. And then on, all conditions are coded. That's really, optimizing your opportunity in terms of, hey, here's my patient population. Here's the conditions that they have that are still present, specifically your chronic illnesses, higher RAF score, higher expected spend. So moving on into more of a real world example here, just to try to bring this point home, is if we have a patient who presents with diabetes, and they have some other conditions that are associated, they can have a benchmark or predicted spend of $11,500. Their actual spend on a year is $11,750. So when we're sitting down a provider, say, well, here's what your performance is. You've exceeded your benchmark by $250 on this individual patient. Well, when we go back and we say, well, actually, this is a patient who presents with not just diabetes, but they have some complications. In this scenario, it's with nephropathy. Well, just by adding that tag of nephropathy on there, the benchmark will increase because the RAF, or risk adjustment factor, is increased associated with it, $12,000. Spend remains the same. And then you can see the subsequent result of saving $250. So something that specific, more specific, and that's something that you can actually apply, can have a very different result on it. To put this into a higher context, let's say we're sitting down with your population and you have 500 members or 500 patients that are similar to that. Well, that $500 times the $250 swing there, well, it's $500 total, but that's savings, counts for $125,000 in additional savings because your benchmark looks more appropriate. So those are really the key concepts, which a lot of this might not sound new to you, but this is where we're going to go into the next part of this presentation, where we actually go into the practices and work with providers on specific workflows. So based on that, I'm going to turn it over to Dr. Dan Fabius.
So we're going to talk about how we actually educate our providers and ancillary staff. One of the key lines I'd like to just mention that I tell providers the minute I start talking about this is, I don't make the rules of the game. We are told what the rules are, and we try to explain to them, I just want to help you look as good as possible. Because as we all know, providers have a lot of opinions and a lot of concerns over this. This is the system that has been designed. Make that apparent that you're just trying to help them look the best they can. What you have in front of you here is this first step that I do with a coding education, which is just to explain to them how the ICD-10 codes get converted into our hierarchical condition categories, and that certain ones map and certain ones don't. So it kind of de-emphasizes the overwhelming thing that they hear all the time, which is be as specific as possible. That's an overwhelming thing to a doctor. Constantly try to get to a more specific code. Sometimes we don't know. We don't have the answer. We have a working diagnosis. I make guesses for diagnosis and I have to change them. You're allowed to do that. You're allowed to be wrong if that's what your best clinical opinion is at that time. But they don't want to also break their backs over certain things that they don't need to make a decision in that moment. So getting as much specificity as possible when it's appropriate. And what you'll see here is how that conversion happens in some selected primary care codes that we have shown other providers. So what I really like to do is show you some high level, specifically for primary care physicians, and there's more for other specialties that we have, but specifically in primary care, what are some things that we really found that pay off in education, right? Because these providers have a limited amount of time. They need actionable pieces of items. I've had people say, be more specific about heart failure, about this, and those pay off in other ways, in other situations like DRGs, inpatient, and they're important. But in general, heart failure as a diagnosis will get you the same amount of credit. I still want specificity for other reasons, and specifically to risk education generally doesn't help as much. What we do find that's very repetitive is diabetes. People will use E11.9 or an unspecified type 2 diabetes code. We want every doctor trying to give us as much detail. Is this diabetes that it's controlled with no complications? It may not get you as much credit, but I want to know that, because when I see that, I know that doctor's thinking. When I see them using any type of nephropathy, neuropathy, retinopathy, any of these types of codes, which they're probably getting from their referrals, things that they can do right at their bedside is neuropathy and nephropathy. They're going to see that all the time, even if they have proteinuria and a UA, which is not the best, but normally we send out microalbuminurias. So another one that really pays off is the depression. In general now, probably about 80% of the doctors we work with are using some sort of depression screening, specifically a PHQ-2 or PHQ-9. That allows you to have a specific diagnosis of depression, either mild, moderate, either recurrent or a single episode. But if they can use any code besides F32.9, which is the most frequently one that we see used, but also is the only one that does not map to an HCC. That's a high yield tip. And then this one, I'm certain, is one that some of you have already heard before, but morbid obesity. Any person who has a BMI greater than 35 with a comorbid condition, or a person that has a BMI greater than 40 with no comorbidities, those are both the criteria for gastric bypass or gastric surgery, and those both classify from the WHO for morbid obesity. And then the final one we see that missed a significant amount is any type of substance abuse, be it alcohol, opioids, picking some, even if it's been in remission for 10 years. It's important that a physician reassesses this, make sure that the person is still not using. They can use a DASH survey if they choose, or any type of just simple one-line questions, making sure the patient's okay and they don't need any additional help.
Yeah, and to add that as well, when we're sitting down and going through this data, where it's really most impactful is when we're sitting down one-on-one with the provider. When we review the data, what we like to do is we'll tell chapters of a story, but as the physician, we'll know their population and their data much better than we could looking at whether it's claims data or even some of that clinical data. An example of that is, as Dr. Dan pointed to, was the substance abuse. Just because it's in remission, maybe even for a few years or even longer, it's something that, as part of the provider-patient relationship, you're helping maintain that status of remission. So you want to get credit for that. So that's really important. Another thing that's not necessarily on this list that we do see as well is malnutrition. You could have a patient who has had cancer and they're malnourished. Well, that's another opportunity as well. So it's just thinking about all the ways in which you're treating your patient to get credit for that. And help coding for it. And there's other scenarios as well where there also could be potential added fee-for-service revenue dollars as part of that process. So just a couple things to keep in mind.
So the last point I like to remind people is for diabetes, specifically diabetes with vascular complication gets you credit for two different categories, E11.51. So when a provider can determine that they have vascular complications, it is important they note that. Any diagnosis that is used, you must also treat the disorder, even if it is opioid use in remission, alcohol use in remission. The patient is still not using confirmed. Patient does not need any more support. Patient is going to Alcoholics Anonymous. Some sort of treatment plan has to be associated with each one of these. And by the way, it's good care. It's good care to ask these questions and to show that you've done something around their treatment plan. So it makes sense from every avenue, but you cannot diagnose something and put it on the bill if you also did not assess and treat underneath the rule of medical necessity. And the last thing I want to emphasize to you guys is that this is still very important to any program, this type of education, but the proposed rule is de-emphasizing it, where there's a maximum upswing or downswing of 3%. We thought it was important, seeing that the proposed rule came out, that we offer some of the insight around what that means.
So really, to that point is, for these programs, we definitely need to have a risk strategy in terms of engaging the patient population and appropriately risk coding them. But at the same token, what is the impact of that going to be? Depending on the tracks of the MSSPs, there's some strategies that would work versus others that might not work. That's based on retrospective and prospective attribution, and it gets really detailed. But a really important point is it's always good to stay on top of the proposed rules and understanding start of the actions and resources you're going to take to implement it, what is the ultimate result going to be? And the proposed rule is taking some of that opportunity potentially away, but it's still good to maintain those risk scores on an annual basis.
All right. So once the provider's actually selected a code that gives you more credit, how do you make sure that it actually gets to that claim database? And that's where it really matters. And if it does not get through to the claims database for the payer, you will not get credit for that code. And we see this happen frequently. So understanding where your cutoffs are. The first thing I tell people is prioritize your diagnoses. The first primary reason that the patient's here, be it for a URI, diabetes, whatever it is, you can't control. The primary diagnosis has to be one, the reason for the visit. Everyone after that, it's up to the physician's judgment on how they prioritize. And what I tell the physicians is I said, higher risk diagnoses should go towards the top. You should take the time to prioritize them because they are being considered more important in general. If you don't agree, you can prioritize it any which way you want to. But my suggestion to you is put 2, 3, and 4, 5 in the order of things that I've talked to you about. If I've talked to you about these diagnoses, you should put it up there. And there's ones that I'll mention to them like COPD, heart failure, and so forth. Ones that they don't miss. But if you talk about those diagnoses, vertebral fractures, these are all different categories. You need to know the EMR, the cutoff of your EMR. My EMR allows me to send 12 diagnoses per bill. You need to know what your revenue cycle management team's doing. I have had people in small primary care practices working with small billing companies who send 8 codes, and that RCM company only sends 4 to the clearinghouse. The reason that they do that is, quote unquote, they don't think it matters beyond that because from a billing perspective, only 4 problems maximize the medical decision making. This is an education point with these RCM companies. You should know your clearinghouse. The clearinghouses, some of them, most of them now are not doing this anymore, will cut off diagnosis at a certain limit. And then the payer even has a limit which they will even accept. Most will accept 12. When you can go through the entire process, you should be able to get 12 out. Not saying that your doctor needs to assess 12, but you shouldn't limit your doctor's ability to send codes out. Your doctor should do what they do to help you get the best credit you can. And don't lose an opportunity to appropriately evaluate your patient. Always take an opportunity to get every patient in. If you don't see the patient, you won't get credit. So working with your referral network. So we've talked about the primary care people, probably the tax ID numbers, the TINs that are associated. Sometimes specialists are in that, but a whole lot of your specialists will not be a part of your accountable care organization. So you want to leverage them as well. How to leverage them is a much more complicated question. But I always say, if you're within a health system, you should be educating everyone, and you should create a top 4 points like I did with primary care, which we've done in cardiology, OBGYN, a few of our big ones. We have big return on investment for education, orthopedics. Don't limit your ACO is the big point and the message you should understand. That's how you're going to impact. Every bill that goes out to a payer is an opportunity to appropriately judge the risk of your population. And the more providers and offices that have this education, the better. And the front end staff learning about this too can help remind the provider. They can help change super bills. They can help change things to optimize the opportunity. And it's all about being appropriate. We're not trying to overcode or undercode. We're trying to appropriately code these patients. And then incentivizing them. This is a mixed bag. I have seen accountable care organizations and shared savings programs actually put people in shared savings distribution plans that were not a part of the tax IDs. They say, you're a part of our referral network. We are going to allow, if we win, we all win together, because they can also help reduce your utilization. They could help keep people. I'm going to send this person to an urgent care. So putting them a part of that is a possibility. I'm not saying I've seen that across the board, but it's a tool and an idea to consider.
But part of that too, in terms of incentivizing them, and we like to optimize his workflows as best as possible, is that unfortunately, the loop doesn't always get closed. Part of that you might see in terms of, well, here's the quality gap measures that we need to close on an annual basis, whether it's the full population or a sample group of that. A prime example of that are patients who are coming up to the primary care physician as having heart failure. They might have been admitted, gone to a post-acute, gone to a specialist. Some of this all unbeknownst to the primary care physician. Primary physician says, well, this is a patient who doesn't have heart failure. The LVEF reading comes back less, greater than 40. It's some of those opportunities where the specialist or some of those other ancillary providers might be coding something, and that's where the appropriateness comes back to it. And at the same token, this might be a new diagnosis that the primary care physician is unaware of, so then in the subsequent years, they can now make sure that they're managing it.
So we hinted at this previously, but engage the patients. If you've only seen half of your population in a yearly visit, then that's only half of the population where you're going to get an opportunity to appropriately risk adjust them. And that could be with any provider. That could be with the primary care provider. The way we handle this is Medicare allows for one clear 100% covered visit a year, which is that annual wellness visit. We try to drive our annual wellness visits volumes through the roof. We try to get 70 to 80% of our population in for annual wellness visits. And the reason for that is not just it's a cost-free visit for them, but it's also an opportunity to assess them, doing a questionnaire. The annual wellness visit doesn't require a physical exam. You can ask questionnaires, you can go through them. How are they doing with their finances? Establishing old diagnoses and new diagnoses at that visit. And then billing them appropriately with all of the things that we've discussed previously. We've done many different methods. And each one of these may only give you 1% or 2%, maybe up to 5%. But each percent matters here. It's a significant change in your RAF score potentially. And setting that benchmark even a little bit higher can be the difference between winning and losing. That can be robocall campaigns. That could be actual mailing campaigns. That could be one-on-one staff phone calls during care coordination support. We have one organization that actually has a mobile facility that goes out. I'm not going to tell you how to do it for your organization. I'm going to tell you that you should do something. And there is a cost to this, but in general, it will pay for itself by fee-for-service medicine that you're going to be billing. It's going to be paying for itself by the adjustment of your benchmark. That's a significant return on investment when you do all the calculations.
Another component of this is with regard to when the patients are being seen by the physician or provider in practice on a regular basis, preferably an annual at a minimum. It's also what we'll call a data opportunity. When we talk about risk adjustment, it is for predicting future spend, setting the benchmark appropriately. This also factors into other resources or actions you might be taking with care coordination, making sure that we're focusing on the right population for those limited resources. So when we're predicting future costs, when these patients are coming in, their risk score might be changing over time, and where those ones that are your rising risk, it also plays into a part of that as well. So that's part of the importance of the engaging the members as well on a regular basis.
So let's go through our 7 takeaway tips. Document and submit yearly. Document active chronic diseases using monitor, evaluate, assess, and treat. Use specific ICD-10 codes. Learn the ICD-10 to HCC crosswalk for the specialty that you're in. That's important to you.
Yeah, and as part of that, as we indicated, look, there's thousands of these ICD-10 codes that map to HCCs.
10,000.
Yeah, there's a lot. So it's starting with something simple, and that's where the one piece is. What are the ones that we can impact and we see on more of a regular basis?
When you look at these, you'll see patterns for specialties, and there's primary care and a handful of specialties that's going to influence 90% of your bills.
And we've also taken some actions, whether we're working directly within the EMR for these different practices and groups. And we've also created what we'll call super bills that are the paper components to it, where we actually call out specific trends in some of these diagnoses to make sure that they're hitting it not only upon the clinical side when the patient's being seen, but also on the billing side to it as well. When the bill is going out, let's make sure it's not getting cut off as when it makes its way to the payer.
Assess your claims before submitting. Know your cutoffs. For health systems, this is a must. You must map that entire process out. For a small one, independent doctor, it may be very cumbersome for you to do this entire process, and I understand that. I would just tell you, make sure you prioritize those and make sure, if you can, you make sure your EMR is allowing you to submit as many codes as possible. Educate all the providers in your ACO network when able. If they'll let you in, engage them. Work with your referral network, including the ones outside the ACO, and engage 100% of your Medicare patients. Thank you very much for your time.
Yes, thank you, everybody. And Gary, you just want to take it home.
All right. Well, we have a little bit of time here for Q&A, and thank you guys. That was a wonderful presentation. So let's dive into some questions here. Okay. First question is, what happens when you have people with polymorbid conditions and you need to code all conditions?
So I think I touched upon this briefly. So there's a two-part answer. Let's say you're an independent doc and you actually know your codes are getting cut off. Take the opportunity during one visit to code the first one's higher, and then second visit, prioritize the other one higher. Why is that right clinically? Well, between the two visits that you had in the year, or I mean, really honestly, if it's polymorbid, they should have 4 visits a year. That would be the standard recommendation. You should be reprioritizing which one you're going after at every visit. The other thing I would say to you, I think I got a yes from someone. Someone liked that answer. Yeah, rotating them appropriately clinically, and then rotating. The other thing is, again, using up to 12. It's been very rare for me as a physician where I've seen a patient and needed to address more than 12 and had the time to do so. That's going to be the competing priority you're going to have.
Okay, great. We'll move along to the next question here. Are there any EMRs that automatically rank these based on highest reimbursement?
So that's a mixed bag. I'm going to convert that question into one question and then answer the question that was asked. So are there EMRs that convert them for the ones that have the highest risk to change your benchmark? No. There is, Athena does tell you about diagnoses that have been suspected, that have been diagnosed the year before from the EMR, and then the Pop Health tool will ingest claims data and show you claims data that was actually used before. It will not tell you, for example, if your BMI was greater than 35 and they also have diabetes, that you should use morbid obesity. I have not seen an EMR to do that. I've seen a lot of EMRs in my young career, but none that do that. I've seen reports that you can customize to do that. On reimbursement, that is a medical decision making beyond 4 problems. Sorry, I'm looking at comments. I apologize. Beyond 4, the medical decision making will not be influenced. Please note that the proposed rule from CMS, which no commercial payer has adopted, obviously, and it's not even finalized yet, is actually going to be getting rid of the levels of code and medical decision making hierarchy may become less important. I do know that Epic will actually show you in their ICD-10 list of problems which ones convert to which categories of HCC, and the doctor would have an easier time selecting. I would be very cautious telling doctors just to use that as a method, because that can lead to compliance issues and without appropriate education, because doctors sometimes will hear, oh, I should get HCCs and just select them. There was a comment there I'd like to address that I couldn't see, that just came out. Could you put that on the board or tell us what that said?
Yeah, sure. It says, Athena tells us that it is illegal to recommend codes.
suspected conditions is not illegal. And I think that the illegal is not exactly the fraudulent would be the term that I would use. It's not fraudulent to tell people what has been used before on a patient. We do that. Many EMRs do that. The difference is Athena specifically tells us suspected conditions for risk codes. By the way, most Medicare Advantage plans that I'm aware of actually create a suspected condition list and hand it to people participating in value-based programs. That is standard, and that is a well-known thing going on with CMS. This is actually why CMS, part of the reason CMS stopped payments earlier this year for risk adjustment for Medicare Advantage. And that's why they've created an anti-gaming rule to try to decrease the percent change year over year, because it is not only allowed, it's important, but it's probably not going to be as important in the future. But I still think we need a risk adjustment strategy as a nation, and this is the most widely accepted one currently.
Right, and to add to that, I mean, it's really about the appropriateness and the specificity. And with that comes in mind, the confirmation of, hey, is this a true diagnosis on that patient with clinical evidence to be able to support that via an audit, and then specifically in terms of ranking specific diagnoses or suspected conditions with an EMR. It's really around a clinical workflow and who those team members are going to be enacting upon it, whether it's from the provider to the coder. To the billing and the different components of that. And then ultimately, it's part of this is not just the EMR, but it's also the other data that we can leverage. And that's where, we're referring to this suspected condition lists that are created by the payer, or if you have an in-house tool, you're able to create those yourself and enact those and take actions upon those. And that's where Dr. Dan and myself will go out to the practice providers, and that's all part of that process of reviewing specific patients with the practice and provider to get a little more insight, knowledge there. And then if there's, here's a patient that hasn't been seen, hey, let's get them in this year. Let's confirm those diagnoses. If they can be a little more specific, then let's make sure that happens, and then it gets communicated to the payer on an annual basis.
One last thing, we know someone mentioned that the audio keeps going in and out. If there's some sort of key concept, please just send us a message and we will get back to you on that. We could either do that today or via email.
Okay.
Next one.
Great. Well, let's in interest of time, we'll move on to the next question here. This is from Vikram. What is the lowest hanging fruit that we can ask of our ACO providers, or what's the lowest hanging fruit we can do on behalf of our providers from the flat claims we receive from CMS on a monthly basis?
I'll take that one in working with these flat claims on a monthly basis. So there's a couple different ways to look at that. The one would be, do you have, first of all, an ingestion engine where you can take that, normalize it, process it, and be able to really get information out of that flat claims data that you're able to leverage? So I'll run with that part of it. In order to ask providers, in terms of low-hanging fruit, I would put it at an individual patient basis and say, okay, here's the members who are attributed to you. Here's the diagnoses that they've had over the past year or 2 years. Get that list in front of the providers and then have them more or less confirm those conditions. And then look at the ones who have the most amount of, we'll call it your polychronic or your polycomorbid patients, and have them seen in almost a prioritized order. Specifically the ones that haven't been seen yet or are not scheduled to be seen within the coming months or coming year. So to summarize that, who are the patients attributed to you? Let's look at the claims data in terms of the diagnosis they have associated with them. If you're able to add on any of the utilization data as well in terms of admissions, ER visits, post-acute visits, look at that list, review it with the providers one-on-one. They'll, as we shared earlier, they're gonna know more about their patients and their population than the data is going to show, and they'll close some of those chapters of that story, and then prioritize that list for them to be seen in your office.
Yeah, it's very hard to look at the raw claims file to find opportunities for individual providers. I'm not saying it's impossible. I'm just saying it's very difficult. Without some sort of ingestion method, conversion of ICD-10s to HCCs, looking at individual providers and opportunities, you'll be doing a lot of manual lifts. My only suggestion is taking because you know who the attributed physician is, taking a very small sample per physician that you're interested in talking to preemptively and looking at opportunities within their specialty. Primary care, a great one is just looking at diabetes codes. How many people have a vascular complication code who also have a diabetes without complications? Depending on who you are looking at it, you can see that very easily as a coder.
Great. We have one last quick question, and we will wrap it up for the day. Let's see. Oh, maybe we got through them. Okay, well, very good. Well, thank you, Brian and Dr. Fabius. Again, for those questions that we were not able to get to, although I think we did get them, they will be answered via email. Also, if you have specific questions for any of our presenters, feel free to reach out to them directly. Their contact information is here on the slide in the lower left-hand corner. You can make a note of that, and they'll be happy to follow up with you for further discussion if you would like to do so. Also, wanted to note that on the left side of the slide is the website acoexhibithall.com, and that is where the recording of today's webinar will be available in the next day or so, along with the slides for download. And that will be in the reference library. So that is acoexhibithall.com, and you can do a search for either Continuum or webinars in the reference library to find that. Also, be sure to visit the Continuum Exhibit Hall booth to learn more about them and connect with their team. Again, this is, and what you're looking at here is their booth at the acoexhibithall.com website, and you can do a search for them with Continuum Health. And learn a lot more about them. So I would like to thank you all for attending today, and I hope that you found today's presentation to be informative and helpful, and hope you have a wonderful rest of your day. Thanks for coming.